Obsessive compulsive disorder is defined as a condition in which patients develop recurrent obsessional thoughts or compulsive acts. So as the name suggests, it splits up into obsessions and compulsions. So obsessions are various thoughts, images, things like that can cause a huge amount of distress, and patients will try their best to resist them, but will really suffer as a consequence of this tension that they create. So the thoughts are recognized as their own, so the thoughts are not necessarily wanted, and they're quite irritating thoughts that really do occupy quite a lot of mental attention. However, they are recognized as their own thoughts, which makes it different from psychotic states. So the obsessions can come in many different forms, so they could just be ideas, could also be certain mental images that pop up in your head, and it could be certain unpleasant impulses as well. Compulsions are acts or rituals, and they are not inherently enjoyable. So it's quite a complex state, really, where patients feel a compulsion to do a certain act or ritual. It's not something that they enjoy doing, and a lot of the time it's linked to something that is very, very unlikely, and the patient themselves will recognize that it is pointless and that their compulsion doesn't really contribute to the thing that they're worried about. But resisting that compulsion causes a huge amount of anxiety, and it often becomes a state where they feel like it's easier just to complete the compulsion rather than resisting it. The first line in the management of OCD is exposure and response prevention. So that's based on the theory that after being held in an anxious state for a sufficient amount of time, the anxiety kind of loses its power over you. So what it involves is essentially subjecting a person to their obsessions and preventing them from carrying out their compulsions. So it is done in a supervised way, and it's done to sort of desensitize the patient essentially and make them realize that they can allow the anxiety to build up and then eventually it will subside by itself. If that alone is ineffective, then an SSRI can be trialed like sertraline and fluoxetine, and that should be continued for 12 months after the patient goes into remission. If after 12 weeks of an SSRI it's not shown any effect, then tricyclic antidepressants like clomipramine or alternative SSRIs should be trialed as well.